What's this term called micropenis?
Penile length is less than 7 centimeters, we consider it to be inadequate. If it's less than 5 centimeters, it falls into the micropenis.
Would masturbation cause infertility?
No.
No. Would masturbation cause hair loss?
No.
Would masturbation cause acne?
No.
Would masturbation cause more stress and less libido and everything?
No.
Are there any advantages of masturbation?
So sometimes we actually advise frequent masturbation.
In women, G-spot, O-spot is a huge topic. Is there anything known as a P-spot?
But men don't require any spots. Men have it in their brains itself.
The B-spot. Penile size. ऐसा कुछ होता है क्या कि इतना होना चाहिए या whatever?
Men need to understand this. You will rarely be able to increase the penile length to beyond what is the natural maximal penile length.
Hello everyone and welcome again to yet another episode of Second Opinion with Dr. Yuvi, a podcast where we drill into the ins and outs of health and plus the lives of a doctor in different specialities, their wins, their losses, and of course, altogether, your health per se, the rights, the wrongs, the taboos, the false information, the right information. Today, I have another interesting guest, someone who I've had the privilege to work with for a while now, and he's my go-to person when it comes to male infertility or sexual health, a branch that has now come to be known as andrology, gaining more and more popularity in terms of the need of sexual health, which is the need of the hour. I have Dr. Vineet Malhotra, sir. Hi, sir. Welcome.
Hi, Yuvi. Thank you, and it's great to be on this show.
Finally, Dr. Vineet Malhotra is a senior andrologist. He's from Delhi, but I've had the privilege. He comes to Gujarat for his routine surgeries, and we sometimes work together. He's the medical director of VNA Hospital, Delhi, Malviya Nagar, and has apparently, I could say, as I said, my go-to person, but also one of the go-to people where andrology and men's sexual health is concerned. So my first question here is, most of the times, even as doctors and for general people who are listening, the difference between a urologist and an andrologist. That's the first question, because I think still a lot of people don't really know the difference of who's a urologist and who's an andrologist. When do you skip the urologist part and go directly to an andrologist?
Very interesting question, and it's great that you've mentioned it, because andrology is really not yet recognized as a separate specialty, even within medical specialists. So when you deal with all of urological diseases, which means diseases which can affect the urinary tract, kidneys, ureters, bladders, prostate, that's the urology entire field or spectrum. And when you deal with particularly diseases that relate to the genitalia, which means the male genital organs, and diseases which may be related to it, such as sexual health, fertility, or sometimes even discomfort or pain disorders that are associated with these, then that is andrology. There is another field that's called andrology, which is the laboratory part of examination of semen and factors related to fertility. So in fact, I used to face this dilemma, and for many years I didn't understand how I would get across it. And somewhere in this time period, I thought I should try to coin a word which should meet both these requirements. And in one of the meetings that we were having in our national meet, I put across the word that I'm a uroandrologist. And now a lot of people tend to understand that, because that gives the perspective that my background is urology. And I deal with male sexual health and fertility and those factors, and hence a uroandrologist.
So you started your practice as andrologist itself, or it was a transition from urology to andrology?
Again, there's a slight story behind this, but I was very fortunate. So my mentor, Dr. Rupan Shah, was considered the father of andrology in this part of the world. And he was my mentor and guide and teacher. So it was a natural, factor for me to actually take up andrology. It didn't come in as andrology in practice altogether. And the early part of my practice was also a lot of general urology. which now is moving towards more and more focused andrology, as I am also now teaching and a guide to a lot of students now, and hence now focused on the andrology.
So people who are listening, if I'm a urologist and you're an andrologist, when should they directly come to you? What are the diseases that they face or problems that they face when they directly need to come to an andrologist?
I wish everyone actually did that. Unfortunately, it doesn't happen like that. A lot of the patients that actually end up coming to me end up by perforce because they've either been referred as a last resort or have not found treatment elsewhere, and then read and then found out about it. So if if they were to come to me straight up, I would love it if they had any sexual issue, any issue related to fertility, any disorder that they had with their male genital organs, and they came first up. Because understand this, that time is of essence when we're treating all of this. I've had that unfortunate couple come to me at 5 years post marriage, very educated, not consummated marriage, and sometimes the marriage having fallen apart. Sometimes parents bringing in their child because they want to have another remarriage a second time or something like that. And I wish they would be able to approach me much earlier, because I've had the good fortune of having sorted it for so many couples when they made it in time.
Okay.
So this, the sexual health matter, the fertility matter, and we've seen how fertility declines with age. So if they were to come in early, get the appropriate guidance early, we would be able to help out so many more people.
But are you seeing a change? As in, because as far as we are on a social media platform, as far as social media is concerned, sexual health is a huge thing. Like if you want views, talk about sex, you talk about sexual health. Well, more power to people who are actually giving the right education. We know that everyone needs it. But there is this shift that we are seeing, at least on the platforms of internet, but as it converted where real practice is concerned.
So, with any bad, good also comes along, as the vice versa also holds true. So, for every 10 channels that would probably give information which may not be accurate, there's someone like you who'd give out accurate information. And that's what makes the difference. And with disinformation, you have information, which is why I'm happy whichever way this goes, because information will make people come and seek something. The problem was lack of awareness, the lack of this discussion at all. So you've gone from one end of absolute taboo to obscenity and profanity. And if you are going to reach a balance somewhere in between, it's fine.
Correct. But do you see more young patients, young women, men, or older men per se, directly now coming to you? That's what we were talking. They don't come on time, but now, like today, we had an 18-year-old who came for some consultation. Are we seeing that more and more?
A lot more. And I'm seeing people come in on their own. I'm seeing couples come in. I'm seeing women come in and talk about their husbands. I'm seeing parents come in and talk about their children. I'm getting video calls from across the globe, actually, for people that want to discuss something. So yes, definitely. I think people are far more forthcoming now. They're ready to discuss issues which probably would not have been discussed at all. We're talking people that are talking about same-sex problems. We're talking about people that have issues, gender reassignments, things that have never been spoken about openly before. But we have people that are willing to talk about it. And that's where it's good, because, you have the choice to then make the right decision.
So, sir, if we say, for example, if you just want to count 4 or 5 ailments, diseases, or situations, conditions that you most commonly today face as an andrologist, what would you put them as?
So, sexual health problems. I would think sexual health problems are by far the commonest things that we see, more than fertility, because I think fertility is handled by the fertility experts, the IVF experts more commonly before we deal with them. But sexual health problems come into us. And I would think premature ejaculation is one of the commonest things affecting men in our country and also worldwide also. So is one of the problems that we see very commonly. Erectile dysfunction is another one, and we find men, women, couples come in and complain about that and seek treatment for that. Of late, we've started to get other health issues also, pain associated with the organ, discomfort with the intercourse and other such things that have also come and become common now.
So glad you brought about that topic. Again, erectile dysfunction and premature ejaculation. Lot of misconception, lot of misinformation, be it be it Google, be it internet, be it social media, be it the porn industry. Uh, there are a lot of questions when it comes to premature ejaculation. We'll take one by one. So premature ejaculations are like we see patients. One, when do we actually, because that's the biggest concern. Most of the times, even as gynecologists, sometimes when I have a patient who comes to me and says that, I last only for so long, and you would be like, that's absolutely fine. Their whole concept of how long to last because of movies and porn has just changed. So tell us first, what is premature ejaculation? When can one think that, all right, now you fall into the category of premature ejaculation, and what do we do next?
So if you look at it from a point of view of definition, and it's been a confusing thing. Even for the society itself, when we've had to define, we first tried to define it based on time. And there was something known as intravaginal ejaculatory latency time, very complicated term. Simply put, it was the time to ejaculation post penetration. And they used to have a time to it, which means if it was considered normal, if it was more than 2 minutes, abnormal if it was less than 1, and then you had men that actually ejaculated even while they were undressing. Severe forms of early ejaculation. It didn't fit into the symptom complex because it never spoke about how it affected the psyche of the patient, the psyche of the couple, and that's where the problem was. So the answer actually lay in satisfaction. So now we've actually moved from that time aspect. So it's not how long he lasted, but were they satisfied as a couple? And sometimes couples would be satisfied with very early ejaculation, and sometimes it could be a lot longer. And then you come up with other issues also, because there could be issues in terms of frigidity in the woman, or in the man himself. You could have delayed ejaculation as a pathological cause. And which is why time went away. When the man says, I'm tired by the time and I've still not ejaculated at the end of the act, there's a problem there. Or he says, we've been at it, but she says she's not had satisfaction at all, and there's some problem there. So now you're looking at it as a patient and partner satisfaction rather than just a time-based outcome. That's what's got to be managed.
But then, funnily, that's a very gray area. Because as far as we see, men would never be satisfied with the child.
No. So if you actually ask them,
Correct.
You'll find a lot of men saying that come in, especially that come in with ejaculatory difficulty. Now look, we always talk about early ejaculation as a problem, but there's another condition which is called anejaculation, which means no ejaculation despite adequate intercourse or duration of intercourse. And these men are not satisfied also. In fact, that's an independent cause of erectile problems. So it's not as simple. It's not the fact that it's only early ejaculation which bothers. There are couples and men that are actually bothered by the fact that they don't ejaculate at all. So the balance of satisfaction comes in between.
Is all right. They don't ejaculate. That we understand. But then where do you draw a line when someone comes to you and they say are ejaculating, say 5 minutes, but ideally 5 minutes would be a good time, intravaginal latency time, but they say I want to last 10 minutes. Does that also work, or how do you differentiate it?
So you don't try to differentiate. A patient has come to you with a problem. Someone's come, and you'll see if that is a real problem, whether you can help with it. It's possible that they're not reaching it because he's not stimulating himself in the right way. And just change of position may help. So every situation is an individual situation, and you've got to address it individually, which is why I like to look at every couple or every patient as an individual that's come to me for a particular problem. If I'm going to make an opinion not based on my understanding, I'm not listening to him.
Correct.
He's come to me with an issue. And if he needs a solution for that, I've got to identify. If I find that he doesn't need I still got to guide him.
Correct.
So I've still got to tell him and explain to him and make him understand, comprehend, look, this is how it's going to be.
Yeah.
And this is how you can possibly increase it, maybe get a little better, but you've got to somewhere balance. And then making him understand that.
So then what's the first step? Like, how do we go about when someone comes with premature ejaculation? of course, one point comes oral medications. First, it is treatable.
So yes, it is treatable. It is managed depending on. So when we divide it, early ejaculation or premature ejaculation is divided into that which is lifelong or primary and acquired or secondary, and it essentially means that there is either a inciting factor for why that has started to happen now, had never happened before, or has always been present ever since he's been sexually active.
Correct.
If it's primary, it will require some form of treatment forever. It's very difficult for men to understand and fathom that they will need treatment forever for anything, for even something as simple to treat as premature ejaculation or erectile dysfunction, because they would want to come to you for a cure. They'll say, I want to get rid of this. And for you to tell them, no, this is not a disease. It's something that you've been kind of born with, and you've got to manage it forever. So, it takes some doing. You can't hit them with this idea straight up. You've got to gently make them understand that, look, that's how it is. Equate it with a chronic condition, something like a blood pressure or something which would require management on a long-term basis. And then tell them that, this is how your body clock's been made. And you've got to keep correcting your body clock so that you can reset it to another time.
So what would be the most common cause? Is it stress, lifestyle, or then there is an internal pathology that lies for premature ejaculation?
So for acquired premature ejaculation, because now causes come in for acquired, the early one, as I mentioned, the primary one is idiopathic without a known cause, is usually conditions which can cause urinary inflammation or infection. So say a prostatitis can cause early ejaculation to start for someone that's never had it before. Diabetic men will tend to have premature ejaculation, and that may be one of the presenting features of why he'll start having this symptom. So, you should look for reasons if someone's come in with something that's new, has not happened before. But otherwise, it's fairly common, in fact, far more common to have it as a primary disorder.
And we see these ads very commonly, where you have these sprays and gels that are used for premature ejaculation. Do they work?
Yeah, they do. So what's the idea behind it is that you're going to numb the sensory. So if you understand ejaculation, it's going to happen by a stimulus, which can be visual, which can be some physical, even on auditory, on phone sex. Sometimes it's physical on touch, on vibratory sensation, as we've seen with intercourse. Depending on which of these you can modify, the one that can be modified most easily is the one that's on touch.
Sensation.
And if you reduce the sensation, particularly at the most sensory part, which is the undersurface of the attachment of the foreskin to the penile shaft, that's at the frenulum, then you may reduce premature ejaculation and increase the time in a
But would that hamper your pleasure?
Yes.
It would.
So there are certain preconditions. It should be taken care that it's wiped off and cleaned off before intercourse is had with the partner. Otherwise, it's going to reduce sensation for both the man and the woman. And irrespective of you wiping it off, for the man, it does take away a lot of the sensation. So in spite of that, there are men that are willing to do that because they want to satisfy their partners. They've had issues in terms of emotional distress. But a lot of men will not, accept this because it takes away the pleasure of the intercourse, and therefore they'll look at other treatment.
So then what do we do, sir? We give the medications.
Yeah. So as I mentioned, counseling, position, there are certain exercises, Kegels that they can do to try and delay the ejaculatory time, and then oral medication.
And oral medications are effective.
So they work in at least half the men that they're used in.
Okay.
An important difference is to be made between erectile dysfunction and premature ejaculation for both conditions. Sometimes men that have premature ejaculation will come in and say that I have erectile dysfunction, and some of those that have premature ejaculation will say they have premature erectile dysfunction. So you've got to differentiate whether he's lost the erection before he's ejaculated or not. if you're able to do that, then treating both these conditions by medications usually will work in most of the men.
So, a few common concept, right or wrong, you have to tell me when it comes to premature ejaculation. Of course, first was but what we discussed. Do these not prescribed but market available sprays and gels? Can people use it before they come to a doctor? What would you advise? Yes or no?
I mean, see, yes, I would think if they
And
accept it,
correct.
they may use it because these are easily available off-label. There's so much taboo. No one wants to visit a doctor, and for a man to come in and say, "Look, I've got sexual problems," it's the biggest hit on his ego. So, I mean, give him a break. He can use.
So second, there's also this concept where people believe that you masturbate more, so you kind of maybe, and then you can or you masturbate and then undergo or try to have vaginal intercourse so that you will last long. Is there any?
So it's known that the interval to second ejaculation may be more delayed after the first ejaculation. The problem is a lot of men will not get a fully rigid erection thereafter.
Second time.
So, it's a little bit of a gray area. Some men manage with that even before they come into you and they say they've been doing that. It's not always the easiest solution. So you may sometimes need to prescribe something to them so that they can get better second erections and then ejaculate again. It does work.
A lot of people also believe that, so then you have more frequency of intercourse and then it's better. That's a bad
in terms of, you're talking for the fertility.
Yeah, no. Premature ejaculation. So people say that, like if you're having, say, once a week or maybe once every 10 days or 15 days, have sexual intercourse daily. So
in terms of increasing the frequency with a reasonably long interval, which is greater than 24 hours, it wouldn't make so much of a difference to the ejaculatory levels. We are talking about those that follow immediately, which means that you've had one act and then within the next 20 minutes or 30 minutes, you try another time. So it's that time that it really makes a difference at. Otherwise, there are a lot of other myths that are associated with masturbation. A lot of men believe they have premature ejaculation because they've masturbated early in their life. A lot of men believe that they have erectile dysfunction because they've masturbated early in their life. Masturbation, these are all,
that's what they believe.
So, masturbation myths are abundant, and the important thing to understand is we do counsel men to go easy on masturbation when they're attempting fertility, or if they're facing difficulty with partnership issues, with partner issues, because the arousal may get affected. Most masturbation attempts are done with fantasies and such. And if you're not able to reach that level of arousal, some men may not get stimulated enough. So if the libido is affected, if the arousal is affected, yes, you could go easy on the masturbation. But otherwise, it doesn't have any physical side effects.
Masturbation is a huge debate, especially on social media. There is this whole group of whatever people we might call them who believe this. In fact, it's No Nut November. Just coincidentally, there's something known as a No Nut November. Okay. That means men are kind of pushed to not masturbate or do anything in the whole month of November, because there's this whole group who believe masturbation is not good for your body, it's not good for your health, it's not good for your fertility, it's not good for your mental health, it causes a lot of other issues. There are people, in fact, I don't know what to call them, religious people or some Ayurvedic people who believe not masturbation gives you some superior powers.
So there is a lot of history behind this. Not all of them, not all of it is Ayurvedic. In fact, a lot of ancient belief was that the semen came from blood. And when you lost it, you either lost significant protein from the body or you lost blood. And that's where the myth of how what we call the Dhat syndrome or similar across the world have happened in all kind of civilizations. So again, when I used to be younger, I used to confront and contradict a lot of people. I tend to be more reserved in my judgment now. I tend to be not too judgmental of someone who wants to have another belief, but I'll at least try to point out what I believe is right without being confrontational. So for those that have that belief, very good, and you may have it, but the scientific belief would be that semen is not from blood, and you do not lose, you lose some sugar. So in fact, if you're looking at some weight loss, you could look at more masturbation, but you're not going to lose protein there.
Okay. So, would masturbation cause infertility?
No.
No. Would masturbation cause hair loss?
No.
Would masturbation cause acne?
No.
Would masturbation cause more stress and less libido and everything?
No.
All right. Are there any advantages of masturbation?
So sometimes we actually advise frequent masturbation or frequent discharges, especially in fertility. If men that have high DNA fragmentation index and you want to bring it down, we know that frequent ejaculation can result in lowering the DFI, increasing the fertility. Similarly, if men have seminal infections, we advise frequent ejaculation because that allows the infection or the bacteria to get cleared from the body. So yes, there are certain medical conditions where...
And we also read that the chances of prostate cancer decreases. Is that...
Yeah, there is some evidence to that. Again, not very concrete. It's like you would deal with wine or coffee and take it which way, whether it's healthy or unhealthy. But cancer per se, not that kind of evidence that we want to look at. But for the other things, definitely medically indicated. So, there are conditions where we'd ask the man to ejaculate more frequently.
The second or the third big pain point in a man's life is erection. And I guess that's where it's the crux of an andrologist practice, I would like to believe. So, one, are we really seeing more erectile dysfunctions? Because we know that, sexual health or mental health or stress factors, they're just increasing, pollution, whatever. So are you really seeing that, because you've been practicing for years now, that real rise? And if at all, why do you think so?
So I think there's both factors. One, I think there is an increase in the incidence, and I think there's a lot more awareness. So a lot of people are more forthcoming. So we're listening to a lot more people now because they're coming forward with this. I remember this, in fact, very, very interestingly. I remember this talk I had very early in my practice. This was a senior citizen club where I'd been called to give a talk on, and I was giving a talk on prostate. And me being me, I spoke about treatment for prostate, which would result in erectile dysfunction. And I was blasted by this 60-year-old gentleman who got up and told me, how dare you talk on this fora where everyone here is above 60, we're like your grandfather's age, and you're talking about sex over here, and what is it? And I was amused because it was one of my very early talks that I was giving, and I thought I was being informative by telling people about it. But one of the early things that made me realize that you've got to be empathetic to everyone's point of view. And maybe whenever you're imparting information, give it in that way where you think they can be more receptive to it. So yes, very common now. Unfortunately, I'm not seeing that kind of response anymore. And I get people even at 80 coming and talking about their erectile problems. In fact, I've had to do surgery for someone that wanted to maintain or retain his function at 80. So now we have people coming in and talking about it. But there's so much disease around, and the incidence of stress, disease, metabolic syndrome as we call it, obesity, hypertension, all of these, diabetes, has risen so much that we're seeing a real increase also, so percentage increase also.
There's a lot of information regarding erectile dysfunction, of course, there's everything everywhere, but so we used to read on, so we have these reels going on social media that itna erection ho to grade 1, itna erection ho to grade 2, or so is that scientific one? And so then which grade is somewhere where one should come to an andrologist?
So we have something that's called an erection hardness scale, which is graded into 4 grades. EHS 1 is elongation without rigidity. EHS 2 is rigidity not good enough for penetration. EHS 3 is rigidity good enough for penetration but not fully rigid. And EHS 4 is fully rigid. 3 and 4 are satisfactory for a person to have intercourse, for a male to have intercourse. And the simple logic is it's the rigidity which is going to define the pressure that can be maintained against a resistance. And so that's the scale that should be followed. Unfortunately, there's a whole lot of misinformation also, so for men that don't actually understand how erection works is the kind of information that they'll give out. And if you understand this, it's very simple, most men will be able to place themselves into one of these grades very, very easily. The other thing that has to be remembered along with this is that erection is controlled by our sympathetic and parasympathetic nervous systems. So erection is going to come in with the parasympathetic stimulation and detumescence by sympathetic denervation. And
detumescence is loss of
erection. Sorry, I'll just put it. I just got into some medical jargon. So hardness will come in through a different set of nerves, and softness will come in through a different. Now, when I say all these medical terms, sympathetic means the fight, flight, fright response. That means the response that you get with stress, which explains why when someone says, I get a good erection, but as soon as I'm going to get intimate with my wife or partner, I lose it. And that's where the anxiety comes in. And if they understand that that's the physiology of erection, stress works against the erectile response. And as soon as they will get it, they might lose this. So if they sit on this particular problem where they lose the erection because of anxiety, their dynamics are all right inside. Everything is all right. It's the stress that's not letting them do it. And there's treatment for it. There are ways by which this can be managed. But it's got to be understood by them. Sometimes this is a problem for the couple also, because the woman will say, he has a problem. I don't want to live with him because we've been married for 3 months and every time we attempt, she loses it. Or she says, this guy is unfaithful to me, He is not interested in me at all. Every time we come close, and before that, he's jolly well good. He's masturbating and he's happy. But as soon as he's going to attempt with me, he'll lose it. And you've got to make her understand that, look, this is not actually him wanting to lose it, but losing it because he's trying so hard to please you that he's stressed about it.
Correct. It's an interesting way to look at it. But so then, once someone feels that they have erectile dysfunction, the first response is they go to a pharmacy and buy a Viagra.
Yeah.
And sometimes probably it works. So let's discuss a little bit more about that. So one, why should you not do that? Or can you do that? If yes, then it's all right. But if second, then why should you not do it?
So it's not permitted. It's not legal to do it. So I can't prescribe you to do it. Any medication which is a drug that has to be prescribed this is a prescription drug. It's not an over-the-counter drug and should not be sold or bought as one. So it's illegal. Other than that, there are a lot of myths about using sildenafil or other oral medications for erectile dysfunction. So important to understand they're safe. In fact, when they researched for them, they were researching for cardiac disease, pulmonary hypertension. And this came in as one of the very, very wonderful adverse effects. It works in a lot of men, which is why this is so often bought as an over-the-counter drug. Works in so many men before they come in to see us. So, yes, it is the first drug that's going to be used, but is a prescription drug. So, because the problem is if you face any adverse effect, you'll just not know how to deal with it. And there are certain contraindications to use of the medication. You will not understand them. Some of them, the reason it got its, the myth of the bad name surrounded to it was because people didn't understand it. There's a very interesting story behind this. So in the US, if you have a cardiac emergency or any kind of emergency, if you were to, drop unconscious or something, the response earlier on, before this became known, was that the emergency team would come in and give a Sorbitrate to the man because that would be one of the first responses. Now, Sorbitrate will kill you if you've had Viagra. And all the early deaths that happened with nitrates, use of nitrate with Viagra caused death. And that was part of the natural emergency response for so many places. And that had to be understood and it had to be changed and they had to know beforehand whether the man had used any medication or not. So if you've used a non-prescription drug and you end up somewhere where you're given something which then actually makes it worse, it's far better for this to be within
Correct.
things that have been explained to you.
So we discussed, so you said there are some adverse effects that we'll not be able to manage and some contraindications. So what adverse effects are we scared of?
The scared of is are very few. They're the contraindications that you're worried about. The adverse effects are actually not as significant. You have some running nose, some headaches, sometimes some colored visions, palpitations, and they're usually manageable. If there's an overdose, yes, there is a problem. With certain drugs, these may have interactions, especially if they're using drugs used for BPH or prostatic disease, which is also common in that age group. You may have some adverse events like lowering of the blood pressure and flushing. But otherwise, most such men will have mild adverse effects.
And how, so we usually read that one of the side effects which you should be scared of is priapism, which means, elongated or prolonged erection that you don't want, and which in turn can lead to a lot of damage. So is it common?
It's not really common with the use of the drug in the prescribed dose. Extremely uncommon, in fact. Having said that, for men that have other underlying disease which puts them at risk for persistent erections, priapism is dangerous. And if men don't realize that having an erection for a really, really long time, which means that which lasts for 4 to 6 hours, can give them permanent erectile issues, it then becomes devastating, because then managing a priapismic episode is really, really troublesome for them.
These days, of course, the first line of lifestyle management, then you give medications for erectile dysfunction. But I mean, even before I know you, I knew that, you also specialize in implants. So which is like, I think, the last resort. So interestingly, I think that would be an interesting conversation on knowledge for people to have, that what are penile implants? How do they work? Who are you? Who do we do them for? And what's the advantages of it?
So the treatment algorithm for erectile dysfunction goes from medical management to intrapenile injections. And for them that these things don't work, or if they don't want to have injections, then penile prostheses or penile implants are the definitive treatment. It's the only corrective treatment for erectile dysfunction. When we talk about erectile dysfunction and men say, I want to be cured, all other forms of treatment will be either on demand or will be used for that particular act. For making it corrected without requiring treatment again, actually penile implant is the only treatment. Having said that, it's not going to restore natural erections. So if an implant is put in, then the erection and the act is supported by the implant within the body, and hence it is the last resort. It's never the first resort or even the second resort. If everything else fails, the implant will work. And there are several types of implants. You have the malleable or the semi-rigid implants, which give good function but don't allow much concealment, and hence men will, and it gives a little bit of an unnatural feel, so they may or may not use it. And then you have these very expensive inflatable implants which work as close or mimic as closely as possible natural erections, and a lot of patients are very satisfied with them. So for the appropriately selected patient, one that is not responding to medical treatment and wants to look at permanent solutions, a penile prosthesis is an excellent.
When you say very expensive?
So the overall surgical treatment in these patients may exceed 8.5 lakh rupees. So that's a lot of cost.
For all kinds of implants?
No, for the inflatable. I said the very expensive, very inflatable implants. The other ones, depending on whether you're using the Indian or the ones that come in from outside the country, usually cost in between 1 lakh and 2.5 lakh rupees.
So that's a one-time cost. It's a surgical
It's
cost.
a one-time surgical cost to them.
Is it covered by insurance?
No, unfortunately, this is not covered by medical insurance.
And the sensation, orgasm, pleasure remains the same?
So the sensation remains the same, the orgasm remains the same, the ejaculation remains the same. A lot of men have question about ejaculation, and yes, they will ejaculate in the same way. It doesn't affect urination. The urination happens as it would have previously. So it doesn't affect other systems in the body.
And it's safe. Like, what's the success rate, or is there complications?
The one thing that we are concerned about is the possibility of infection. The incidence of infection is now extremely low. We rarely ever see any kind of infection, and that's the basic complication that you would have to worry about. So it's extremely safe procedure, has an extremely low incidence of complications if done appropriately.
How much would you have? How many implants would ballpark figure आपने किया होगा sir?
I think I've done a lot. So in the last 20 years, I've been doing penile procedures. Having said that, I'm concerned by the rising incidence of implants in men that don't need implants. And I've never been someone that would want to put in an implant that did not require it. So this word of caution always goes in when I talk about doing penile procedures that, you can't be a 25-year-old coming into me for treatment which doesn't warrant an implant and then ask me to do an implant in you. That's not the right thing, and you'll probably not get it from
But are more people doing it, or is it still like very only super specialization and few people do it?
There is definitely more number of people doing prosthesis now, especially the semi-rigid variety, because that's a far simpler form of
And
procedure. It's also inexpensive. However, having said that, I would suggest that anyone going in for an implant procedure should go into someone that he feels has enough expertise to handle situations that are uncommon or not from the ordinary.
Correct. We're talking about penile implants, so that brings to another very, very hot topic on internet and also in society is the penile size. And men, rightly or not rightly so, are obsessed with the size of penis. Apart from that, that's not the issue. But the issue is then the whole marketing that comes with tablets, again, the oils and these lubricants which will increase the size. People fall into the trap of it. So one, as like the scientific authority or a medical authority who deals with this as a doctor, not as a sexologist or not as this whoever lifestyle people or sex therapist or whatever, is there something that you call as a normal penile size? Because I think we, being a gynecologist, we read of something known as a micropenis, but that's a different thing. And one sir, एक तो ऐसा कुछ होता है क्या कि इतना होना चाहिए या whatever?
So very interesting question, because again I think as a person that's always open to suggestions, ideas, and a difference in thought process, I think I've also evolved over a period of time on this. I used to be very rigid in not offering penile size correction to men that I thought did not require it. And I've come to, and interestingly, it happened with someone that was dealing with women far more often and dealing with breast enlargement and breast reduction. And his question to me was, is this question asked to women that want breast enlargement and breast reduction? And I said, no, not that often. They are kind of given the treatment. And he says, why the disparity in how you would treat a man and how you would treat a woman? And it made sense to me. Who am I to judge? And if I were to look at it as a condition, I would have to offer treatment. As long as I don't harm, as long as I don't give the wrong treatment, and as long as the man is psychologically assessed to be not someone that's going to be not corrected by a single procedure, but going to follow up with 20 procedures, as may happen with women also, then why not? Someone may not like the shape of his nose, someone may not like the shape of his cheek, someone may not like the chin. You have different things. And all of those are acceptable to correct. Then why not the penile size? So I have now moved away from the judgmental criteria of what is normal and moved to a more logical way of what can be offered if it is something that's going to possibly make him feel less disfigured, and what will not be corrected, and something that may be probably on a more permanent thing. So a lot of things to understand here. Length rarely changes until unless it's shortened by a particular pathological process. You will rarely be able to increase the penile length to beyond what is the natural maximal penile length, other than by procedures that detach it from its attachment to the bone, in which case the angulation of erection is also affected. So men need to understand this, because otherwise they come back with complaints that, I have longer length now, but I've lost my erectile quality. So we don't try to address as many length issues until unless they're pathologically shortened by a disease process or surgery or something of that sort. And then there are devices, mechanisms, procedures, surgeries that can help with elongation. Girth is far more easily managed. Again, one more thing to understand is that in intercourse, it's the girth that gives the satisfaction far more than the length. The sensory tissue inside the female genital tract is only in the distal part only, and it's the distension which actually gives most of the satisfaction rather than the length. So the girth actually makes more sense than the length itself, and there are simple procedures, safe procedures that can modify, can increase the girth. One of the safest that's being described
Girth
now,
as in thickness.
thickness. One of the safest procedures that is being described now is simple injection of agents of hyaluronic acid. If done appropriately in the right way, excellent way to increase girth for men that require it or want to have it.
So basically fillers for penis to increase the width or the thickness. But then fillers need to be repeatedly done.
So if you're putting in fat as fillers, it's unsightly, it's irregular, and it gets absorbed. Hyaluronic acid is for now found to be the most stable thing back.
Even hyaluronic acid, sir, जैसे face में तो 6 months, 8 months के बाद you have to do it again.
So less of this is resorbed, and you usually don't require it for within a year or 2 years. But having said that, you'd need to have a simple filler, possibly re-injected.
So is it as simple as putting a filler anywhere else in the body?
It would be.
Oh. So interesting, because even as a gynecologist and a fertility specialist, one, of course, so we are talking about the whole ethical part and the judgment part and the freedom of choice, where the autonomy to decide what you want in the body. But then someone has to draw a line, right? Like, just because we are doing breast reductions and breast enlargements doesn't mean that all of them are right. And we all have this problem in the medical and, of course, in the society today, where we are doing these even when they are not required.
So the point that I made here was, one, what kind of advertisement would you do it for? So you'd have to be very clear of not crossing the line there. Second, educating the patient, getting the psychological assessment. I think all of those steps would make some of the patients, less inclined to have a procedure.
These are very touchy subjects. People might not spend for some disease, but they might go and spend millions for.
So if you don't look at it as a business, but if you look at it as something that you're going to possibly go through several channels before you offer it to the patient, the ones that are really, really deserving or maybe inclined to get it done will stick on, and the others will go away. And you've got to make this procedure more protracted for them to actually reach the final procedure, rather than it being that they walk into your clinic, get an injection and go away.
So interesting, sir, what I learned is, even as gynecologist, if someone was discussing penile length or penile lengthening procedures and surgeries for me, even till date, probably I was like, there's no proven technique or method that is advocated as the go-to method for it. But what I understand after this discussion is that there are legit ways to do it.
For the length.
So now we have to differentiate it.
Absolutely.
Whether it's the length or the width.
It's extremely important to do.
So length, there's no.
No, there are.
Okay.
So the release of suspensory ligament and use of traction devices may enhance the length to a more visible length. You're not increasing the length of the penis.
Okay.
You're making more of the visible length increase.
But
because
that's
you're detaching
recommended
it for those that require it. So there, then anatomical length, less than 8 or 9 centimeters. 8 centimeters is usually the cutoff of the visible stretched penis.
But that's
length.
the combination of that procedure of releasing that ligament and traction, because traction devices are marketed like only using traction devices will work.
Only using traction devices work for fibrosis, which means if there's been shortness because of disease. There are certain conditions, perinees, post-priapismic, post-surgery, even post-surgery for prostate cancer, some degree of shortening of penis happens. And you can use vacuum devices or traction devices to regain the length that is lost. You won't gain
There are
length
new
beyond the back,
correct.
but you will regain the length that is lost. You don't need to have a surgical procedure along with it.
Yeah.
In fact, I'm not very fond of the surgical procedure. It's not a really great procedure if you don't make sure that you've put in fillers in between the detached ligament and the penile tissue there. It's going to in fact make it shorter the next time around. So you've got to be very careful with what kind of treatment that's offered there.
So, as you said, just to recap, the length, there's this length issue and then there is this width issue. Length is more tricky, width is more satisfying, more treatable, and in fact, to the extent where you said that that's actually more important to address rather than the length.
So if someone's sold on that, the fact that he's absolutely going to get something, I would much rather give him girth and get away with it, because it's simple, it's inexpensive, it won't hurt him. Medically, I wouldn't have been doing something too wrong, and that's fine. So I would limit myself to penile girth enhancement rather than the entire penile enhancement with length issue.
So then, what's this term called micropenis?
No, there is.
Huh.
You have men that have a stretched penile length which is below the standards. Usually when the stretched penile length is less than 7 centimeters, we consider it to be inadequate. If it's less than 5 centimeters, it falls into the micropenis.
Correct. All right. But that's again a pathological condition.
It's a pathological
Correct. And that is again correctable through one of these ways.
So a lot of things. Sometimes men have hormone deficiencies, very simply treated. And you can do hormone correction and they can get penile length. So, you've got to identify the cause first. If you've got the cause, then you come to the treatment.
Since we're discussing this, interestingly, as we in women, G-spot, O-spot is a huge topic and people are obsessed over it. Is there anything known as a P spot or also the A spot that people or P spot?
So there are areas in the penile shaft that are more sensitive. I mentioned this, when you're looking at early ejaculation, the undersurface of the frenulum, especially where it is attached, is a sensitive area. And triggering a response from there is easy. Any vibratory sensation is stimulatory to the penile shaft, and again, it may trigger an orgasmic event. But men don't require any spots. Men have it in their veins itself, They can
P spot.
because they can think of sex at any point in time, any time of the day, any time of the... So they don't, this is a very popular thing that men don't need to, have emotions or those things attached. They have it in their head all the time. It's the women that need to have an emotion attached to it.
So then we have that O short and G short, and P short was something that got very popular. Is there any truth behind it? Is there any advantage? And what's a P short?
So the P shot became popular as a PRP shot, actually. So it is a regenerative mechanism for increasing penile vascular tissue. There's very limited evidence to show that this actually works. So what has happened now is that most centers will now mix it with vasodilator drugs, so that the P shot is actually mixed with a drug that can actually increase the cavernosal or the muscle dilatation and allow more blood to flow in and so give a response. So it's not purely a PRP, but rather a combined shot of PRP and a vasodilatory drug. And now, of late, something that's become popular, in fact, possibly may become scientific, is the injection of Botox into the penis. Because Botox, again, we know is a relaxant for muscles. And when it causes this cavernosal muscle dilatation, more blood will flow in. And it has an effect that lasts for 6 to 8 months. So you'll have a long-lasting effect for that duration. So depending on what is being used, the clinic will usually not define it completely, because they label it as a P shot and variants are used. Someone will use PRP alone, someone will use PRP with a vasodilatory drug like alprostadil, and someone will use Botox instead of any.
So that's interesting. So Botox for penis. So one, who are the candidates for it, and what advantage would they get?
So, usually, if you have mild to moderate, now we've spoken about what are the regular treatments for erectile dysfunction, but then there are those which are not yet recognized, are not mainstream treatments, but are followed in any case. And one of those is low intensity shortwave therapy, not yet prescribed in the algorithm of treatment, but used practically across the world. It's said that men that have mild to moderate vascular disease, which means they have some blood flow issue to the penis, it's not just stress or psychogenic, will respond to these treatments, low intensity shockwave. And it is those men that will possibly benefit with Botox along with it. To understand what it means is that men that have previously been responding to oral medication either now require higher doses or now not responding to medical therapy. So it's actually also okay ethically, because otherwise you'd have to move them to either intrathecal injections or implants. And it's all right to give a minimally non-invasive kind
So
of
Botox
treatment.
is for erection, not for pleasure.
No, it's for erection.
So P-shot was also for erection.
Absolutely.
Okay, I think most people believe that P-shot is to increase pleasure
Pleasure
or sensitivity.
Men,
But okay.
you're talking about men, you keep forgetting that.
I'm a gynecologist now. Oh, nice. Okay, so we've discussed a lot about the female section part. Now, something that interests me is the fertility part. So, as we discussed, as an andrologist or someone that your specialization, one is the whole sexual part that you deal with, the gamut of it, and that's endless. I think this interesting conversation can go on for hours. And then there is, of course, the fertility part. And I think the fertility part, I want to ask you this question. We have all been reading these articles, and in fact, I also made a reel about it. And that, of course, infertility is rising, fertility is declining. But then at the same time, we're also reading this whole concept of evolution where Y chromosome is losing its so-called genes and functional genes and all. तो पहले तो सर क्या हम रहने वाले हैं 1000 साल के बाद आदमी इस दुनिया में? Or is there any truth to this?
I think आदमी तो बन ही जाएंगे, whether they come in from the Y or the X, it doesn't matter.
That's true. But is this something that's scientific or ये कुछ
Yeah.
article?
So
है?
there is evidence. See, whenever you look at any published evidence, you've got to understand that it's all data that you're creating for a particular point of view, and data can be projected as one way or the other. So whether you want to look at it as the Y chromosome going, you can have data that supports that, and you can have data that will not support that. And it is there as evidence that's been published. But then again, as I said, end of the year, it's data that's been published.
But I mean, you and me, that's where we work together, and the whole idea of infertility and fertility declining in men is huge. That we know, we cannot deny. Why is it happening? What are we doing wrong?
So the same factors that affected erectile dysfunction or erectile function, now we look at fertility and sexual function as the parameter of the entire health of that male. It's not just the fact that he's having an erectile issue or a fertility problem. It's the fact that his entire health is affected.
Correct.
And if you address it as that, you will realize that fertility or erectile dysfunction may be the first marker of a problem that he has. He could have an underlying cardiac disease, a coronary disease, and that may manifest much later, but it's actually manifested as some problem in his semen. And it's just picking that up that may help us identify so many things. So it's actually the entire health, obesity, metabolic syndrome, the fact that he's unfit, he doesn't exercise, has stress, there's so much pollution, there's so many things that may have affected him. We've heard about COVID being, the COVID virus particle being found in the testes of men. There's data that was shown for that. So, fertility has been affected by a huge number of things. And yes, we've seen that declining trend of even what we call so-called normal semen parameters. Even they've shown a declining trend over the studies that have studied them over decades.
And so, I mean, just because we are talking about it, so if there are, say, 4 or 5 points that you want to point out that, at least do these things correctly, to maintain your reproductive, sexual, and fertility health? What would be those salient points?
Very simple things. I kind of tell this to
Every-
all men that
Correct.
come in, that exercise regularly. Cycling is actually the only form of exercise we restrict them from, and all other forms of exercise are fine. We ask them to exercise at least 5 to 6 days a week for an hour every day. Eat healthy, extremely important again. Make sure you don't go heavy on the carbs. You've eaten healthy. You sleep well. A big issue with a lot of men these days, because there's TV that they'll watch or the internet that they'll watch till 3 a.m. in the morning, and then have to wake up for work at 7 in the morning. So a disturbed sleep cycle, or if they're working in a job that requires them to stay awake at night. So sleep pattern which is affected, stress that should be avoided, some form of relaxation. A lot of couples, men nowadays, they will not even leave the Sunday for some kind of relaxation. Even that will be filled with tasks. So find time, the me time that you have to unwind, to relax, find a hobby, do something. And if you've done all of that, then you've kept yourselves mostly well. If you're a couple in a relationship, have regular intercourse. So I had this man that came in yesterday, and he was very concerned. He'd been married for 3 years and they don't have kids, and they have sex twice a month. So, and this is an educated person that I'm talking about. And you would probably give a better opinion, but you have these gadgets that you look at, and you say, today is the day that I'm going to make my wife pregnant.
Yeah.
And that's the day of the month that you'll have sex. Unfortunately,
That's
there are
work
myths
like that.
There are myths like that. So, regular intercourse if you're a married couple, and don't link it to fertility every time. Have it because you enjoy it.
Correct.
And if they follow that pattern, a lot of these men will actually find they don't need anything else.
Correct. You said we don't allow cycling. So that's an important point. Why? And
So again, not as strong evidence that we'd want them to have, but there's evidence against anything that would increase heat around the genital areas. We know varicocele, a condition where the blood vessels around the testes are dilated, affects because it causes heat around the testicles. Same thing with steam, sauna, very tight clothing, or sports like cycling, which may increase the heat around the genital area.
at one point, of course, now it's changed. One point we used to say, men, there is no age. Their fertility is, infinite. But now slowly we've come to realize that men also are affected with age. So is like I get asked this question a lot of times, that is what is the ideal age for a girl to get pregnant? So is there an ideal age for a man to get pregnant?
So my advice to couples usually is try for pregnancy early into your marriage, because the best time is then. You're most likely to hit success. For as early after your marriage you've looked at having fertility, because as you look at duration beyond the married life, the incidence of infertility increases in couples. Having said that, it's very difficult now. I get couples where the man is 47 and the wife is 42 and they've been married now. They got married now. And what do you advise them? I mean, the government has now put a cap at 55 being the upper age of when you can look at yourself as being fertile artificially. But there's actually no age. We've known men that have impregnated women in their 90s also. But you would want 40 to be the cutoff beyond which you understand that there would be changes within the semen that would affect outcomes in terms of pregnancies, miscarriages, failures, etc.
And this whole mobile phones and laptops causing semen. Don't put your mobile phone in your pocket. Don't put your mobile phone near any of those areas. So I remember Rupin sir making this joke that, you decide what you want to, because if you don't put it in your pant, you'll put it in your shirt. So what is more important to your heart or your testes? So you do recommend that no, stay away from these gadgets and these radiations and all?
So, if someone's asking me too many questions, I might tell him,
Rakh do, kya hi farak padega? True.
So I don't give it as a recommendation offhand every time, but yes, Yes, I may ask them to desist from it if I've told them everything else.
Then.
They're still orca. So, maybe that would be the orca answer. There's not enough evidence to show that the effect, but yeah, I mean, what's the harm if you would keep it away?
Proteins and gym.
Oh, big issue. Now, there are two problem areas that I see. One of them is doctor induced, and the other is so called doctor induced. The so called doctor is the gym trainer because he apparently believes that he knows far more than everybody else and will tell the person that comes to gym, look, I have 5 children and I have been using this protein for my life, and you can use it safely, or you can use steroids and there are no problems with that, or you can take testosterone. Very important to mention testosterone because testosterone can actually make you have zero sperm if you use testosterone.
So many patients you have seen.
All the time.
Seen.
All the time. We've seen it prescribed by doctors also. Unfortunate, but now with education, a lot less doctors are prescribing it. But men that go to gym and believe that what the trainer tells them is truth and nothing else should think otherwise, because a lot of these protein supplements, a lot of these supplements which may contain, say, steroids or testosterone-like boosters will have damaging effects on the testes, will have damaging effects on sexual function, fertility, and they must desist from having these. We recommend a graded natural protein intake when you're supplementing for the kind of exercise that you need to do for bodybuilding, and that's what we recommend. And there are enough examples to see men that have in our sports fraternity that have used natural protein and not used other things and had fantastic physiques to go with it. The other that I mentioned was the doctors. Unfortunately, I'm on live social media and mentioning this, but there are so many doctors that want to prescribe hair fall medication and will swear by it that using finasteride does not have any side effects. And we've had to treat a huge number of men either for sexual dysfunction or fertility related issues because they took these medications on prescription by doctors. And now it's, in fact, there's evidence also, thankfully, a lot of evidence that is coming in to show that it should not be used at all. But it's still used fairly commonly, and finasteride is a real troublemaker for both fertility and sexual function.
I'll be the devil's advocate here. Say, for example, we were discussing about penile implants, we were discussing about breast surgeries, autonomy, choice of doing something. Now, say tomorrow, sir, I come to you and, I really want, I don't have the time to work out. I will work out, but I still want that six-pack abs and I want a chiseled body. And someone has told me that taking testosterone will help you do that and will make us achieve our goal faster. So is there a right way to do it, or it's just a no?
So if fertility is not an option, and that should be clearly discussed, and testosterone replacement is being taken, there must be clear understanding that 90% of men will recover in a period between 6 to 12 months following stopping these testosterone and taking something. Again, gym trainers are very good with this. They know the washout regimens. But 10% will never recover. So they must be willing to take that. In this case, you must be willing to take that risk that your six packs are worth that 10% risk. And if yes, then yes, there is a structured way by which you can take this for that duration and then allow it to wash out from your system, take the washout cycle, and then recover function.
So then, can I come to you? Will an andrologist help me with it?
Yeah, we have a lot of men that take testosterone replacement therapy, not just for this. There are men that take it because they are hypogonadal.
Correct.
And they have severe symptoms. And giving them testosterone helps them to maintain their libido, their arousal, their sexual function, and to some extent their erectile function. And they clearly know that fertility is something that they're not going to address when they're taking this treatment. And we will ensure that we follow this up with washout so that, we've corrected it when they so desire.
Correct. And there's no long-term side effects. I mean, we hear these cases or news reports of someone had liver failure because he was taking testosterone, or kidney failure because he was taking testosterone, or could happen rarely?
So, couple of things that have been discussed with testosterone replacement therapy. There's a question mark about whether it helps or makes worse the cardiovascular system. Reports both ways. The one that was of most interest to men is the effect that it may have on the risk of prostate cancer. And there have been a lot of trials that have actually tried to show that testosterone replacement therapy will increase the risk of prostate cancer. It's known now that it doesn't increase the risk of prostate cancer, but if you were to have prostate cancer, it will increase the progression or make it faster. So you have to rule out, in men that are in that age group, you have to rule out the presence of prostate cancer. And if you've had treatment for prostate cancer, then there is a duration that you've had to remain free of disease before you can start that treatment.
But no liver failure and kidney failure and all.
No.
Okay. But proteins also, it's been associated.
Proteins definitely are associated with both.
Protein supplement.
Protein supplements
Yeah.
in excess of what is the recommended
Yes.
usage.
Yes. And the second part is the cosmetologist, the estheticians, the dermatologist who are. So if someone is having hair fall,
There are so many other ways to treat
correct.
it. I mean, this is
So
something
only
that
finasteride causes problem. Like nowadays, the simplest thing, the first thing even over the counter people are taking is the minoxidil spray and regain and all.
local gels and local sprays will not
Fair enough.
absorb and will not cause an impact.
And but finasteride as an oral supplementation is would not recommend.
Definitely going to impact.
Lastly, sir, since we are discussing fertility, it's so very important to discuss: can someone with zero sperm have their own child?
Again, extremely important question, and I think we've seen the answer many times. And with this will come the question of hormones also. Is there anything that precludes or can say with that authority that there can be no sperm production? There is one genetic condition where sperm production is not seen. It's particularly known with a kind of what we call YQ microdeletion finding. But there is no other exclusion factor at all, which means that somebody having peanut-sized testes with hormones that are out of the roof and with any or zero sperm obviously in the ejaculate and any other problem, we've still found sperms and they've had offspring. There are surgical procedures, one of them which is known as microdissection TSA or micro TSA, by which we found sperms in these men and they've gone on to father children. So there's nothing that precludes finding sperms in someone. And if they are keen on only using their own gamete or sperm, then the effort for the same should be done.
I get this question a lot of times when we discuss about micro TC and bad sperms, because it's very simple. The first reaction to semen analysis, which a general public or a general practitioner or a general gynec says that, oh, you have bad sperms. So then they kind of correlate to, okay, I don't have sperms or I have bad sperms, but if I get pregnant with this bad sperm, will my child will also be bad, also called abnormal?
So this is an interesting question, because the problem with bad sperm is that you may have an increased incidence of miscarriages. And so we want to find the healthy sperm. But having said that, not everyone will be able to have a healthy enough sperm. And frankly, we don't have all the criteria to even identify which is that super healthy sperm.
Correct.
So we will use what is the best available sperm. And there are no increased risks. In fact, even with IVF, we've not found any increased risks of defects in children following procedures for fertility. So, no, there is no increased risk of the sperm retrieval procedure or the IVF leading to this, because as would this bad sperm in a natural conception lead to a miscarriage, will if a bad sperm used for IVF.
Correct.
So it's the same ratio.
I always tell them that you want to try naturally. So what's the guarantee that the natural trial that you're giving is going to give you the best sperm that is going to...
Absolutely.
Coming to the end of it, now a little bit about you as a doctor and as an andrologist. Whenever I talk or whenever I do a podcast, we always discuss this one thing where, there are these one or two cases in your life that probably change your perspective or your beliefs, or, they have like a lasting huge impact on that doctor's life. Most of us would have that. Would you want to share an experience with a patient or a procedure or a surgery that maybe it was like a miraculous change or something you didn't expect or something that had a lasting impression on you?
So I think there are some experiences that I've counted as having had a lasting effect on the way that I practiced. Very early on in my practice, I was a resident, in fact, a junior resident at that time, and there was a child that came to an emergency, and required ICU care, and we treated him accordingly, and we lost the child. He was just about a year and a half old. He was the only child of the parents, and somewhere that guilt stayed on. Very early on in practice, guilt stays in your mind, and you tend to always think of you being responsible for outcomes. And I think it made me look at my treatment ethic as a very, very, very integral part of how I would treat my patients. That happened so early in my practice that it kind of laid the foundation of how I would treat medical practice thereafter. Yeah, I won't say thankful for that experience, but it's something that stayed on it. And then something that happened again once I'd become an andrologist, that happened in my practice, which again I think really was gratifying, and something that defined how I did practice was one of my early vasectomy reversal procedures was successful, and the couple wrote back to me, and they put my name as the middle name of the child.
Oh.
And that's happened several times thereafter, but when it happened for the first time, it was a completely, it's an experience which changes your perspective, and the gratification that it gives you is more than what you look at in terms of financial gratification and everything else. So
Agreed.
I think you look at these small things, and they give you satisfaction, and they make you probably work harder for whatever you're doing.
And the other question that we ask everyone is like, there'll be a lot of doctors, young men and boys and girls aspiring to be doctors, aspiring to be urologists, andrologists, or any form of medical practice that they're looking into. What is your advice to them after your experience and you've lived?
I mean, I'm sure this advice has been given by everyone, but medicine, it's a field that you've got to have passion for. This is actually true with any field that you come into. You're going to have a lot of questions. Now, ethics have become even more important because of the challenges that come in with trying to be competitive with your peers, and the kind of awareness that social media brings in, the kind of message that you can actually give out. So if you can remain true to if you can sleep well at night with what you do during the day, that's got to be the bottom line of how you've got to learn, how you've got to practice.
Amazing. Before I let you go, some quick fire questions. Yes or no, whether you would suggest or recommend one over the other. 5 or 6 quick questions. The big debate about boxers and briefs.
So which way do you want to have? I would suggest boxers, but again, evidence-wise, not too much, but boxers, yes.
These supplement to boost your sexual desire and your stamina, this Revital or ye or wo or ye sab, yes or no?
No.
Watching porn damages your sexual life in a way?
No.
No. Okay. Men are more sensitive about their sexual health than women.
Yes.
Does age have a lot to do with fertility?
Yes.
Sex toys, would you recommend them or not?
They're okay to be used.
Okay. That's it, sir. Thank you. Thank you for this interesting conversation. You've done interesting work, but this gave me an opportunity to talk to you, and I think we've discussed some really good topics. There's so many things that I also learned. Thank you so much for sparing the time.
No, it was my pleasure, and I enjoyed this. Thank you so much for having me.
But that brings us to the end of another episode, another very interesting episode of Second Opinion with Dr. UV, with Dr. Vineet Malhotra from Delhi. Sexual health, men's sexual health is a huge topic in our country. Unfortunately, people misuse it because it's a very sensitive topic also. But there are right doctors. Sex and sexual health in this age and generation need not be a taboo. You need not go to someone who's not qualified. There are doctors, legit doctors who will help you, who will not judge you, as we had a conversation with here today. Thank you so much again for joining in. Until we meet next time, stay healthy.